Hussein Al-Husseini is an MA student in political sciences at the University of Alberta, funded by the Social Sciences and Humanities Research Council Master's Award. As a student with cerebral palsy and a periodic stutter, he's deeply committed to disability rights and advocacy, a passion reflected in both his academic work and leadership roles. His advocacy efforts, including co-founding the Council on Systemic Ableism, earned him the Judge Gurcharan Singh Bhatia CM Outstanding Leadership Silver Medal in Arts during his undergraduate convocation. Hussein was also recently announced to be receiving the King Charles III Coronation Medal, and that will be occurring in a ceremony in early December of this year. His BA honors thesis examined how Canadian universities exclude disability students through neoliberal principles and ableist structures. Currently, his research engages with critical disability studies and colonial post-colonial studies in the Middle East. Without further ado, I pass it over to you. Thank you again for being here with us.
Thank you so much for having me. And thank you for the lovely introduction. I'm pleased to be with you all today. Um, I'm really excited to bring this conversation to you and to have this talk with you because this is a topic very near and dear to my heart. I get to begin, I think I'm just going to kind of restate the sort of abstract of my presentation today, um, so you know what to expect. Um, so my seminar titled Ethical Considerations for Understanding Disability in Medicine explores how we can broaden our understandings of disability in healthcare. While the medical model is crucial and does have its place, it's equally important to incorporate perspectives that address social dimensions of disability as well. I'll introduce the concept of the historical university, a term in which I coined to examine how the roots of disability medicalization shape institutional understandings of disability and how these understandings contribute to the ableist structures of institutions today. And I will conclude by drawing on some very positive experiences within the Glenrose Hospital, but also addressing broader systematic issues within our healthcare system in Alberta. All right.
And Hussein, just let me know when you want me to advance the slides.
Thank you very much. You can go to the next one, please. Thank you. Okay. So to kind of address the historical universities, I will begin by addressing connections between the university and the asylum historically. Let us first look at the historical university and the role in shaping our understanding of disability in medicine. Historically, universities were built in close connection with asylums, institutions, specially designed to um, incarcerate and quote unquote fix disabled individuals. The historical relationship between universities and asylums is significant because it reflects how academic and medical practices have always been intertwined. Often, and the determinant of disabled individuals, as Timothy Dolmage points out in his book Academic Ableism, uh, um, it is categorized by able-bodied norms. Uh, Asylums and universities were almost always connected to close proximity of each other, with asylums often acting as places for research and study of the disabled body. The history was and still is uh, uh, formative as part of eugenic practices in both academia and medicine. The connection, while not often discussed, is fundamental to understanding how institutions historically defined disability. The asylum and the university were not only physical spaces of separation, but also ideological spaces that defined who was considered fit for society and who was considered unfit. Uh, Universities, much like asylums, were designed to exclude those who don't fit normative the ideals, and an ideal that was that favored um heteronormative, uh, fully physically and cognitively abled individuals. Um, Similarly, uh, the university institution was created to attract the most desirable within society, and to and in order to establish a collective um, space um, for those deemed most fit within society. Um, so to put it in simpler terms, the asylum was created to exclude certain people from the most desirable within society, and the university was created to attract the most desirable people and bar um, those deemed unfit or undesirable out from full participation in the university. We're talking early 1900s here. Uh, so, so from here, I move to the connection of eugenics and the medicalization of disability. Building on the historical context, it is critical to understand how eugenics became central to the medicalization of disability. Eugenics as an ideology is rooted on the belief that that only certain individuals, those deemed fit, should thrive and uh, reproduce, while those who are deemed unfit should be excluded or eradicated. The concept is deeply influenced by early medical practices, especially as they are related to disability. By pathologizing and medicalizing those considered unfit, disability was seen as something to eliminate rather than to work with and accommodate. The medicalization of disability is critical in contemporary um, practice, and completely has its space and is welcomed. Um, uh, uh, but one must consider other dimensions of of disability exclusion, that being social factors. The medicalization of disability is a crucial component of the medical model that views disability through a lens that sees um, impairment as a deficiency and in need of eradication uh, completely. This was influenced by eugenic thought that viewed disability as undesirable uh, and in need of uh, eradication. Um, while medical treatment plays an important role in our lives, specifically mine, as a person with uh, disability, it is important to recognize that the medical model uh, often um, overlooks inaccessible environments and social attitudes that may marginalize disabled individuals. Historically, eugenics implemented discriminatory policies um, such as forced sterilization and segregation to eliminate disability from society. In the modern context, the eugenic ideologies still linger in the foundations of our uh, modern healthcare systems, while uh, we don't see explicit or um, de or ideology rooted in hatred. The remnants of eugenics still may play a role despite our best efforts. Um, um, to go beyond just thinking about disability as something to eradicate. The way that healthcare systems approach disability uh, is very much focused um, around this idea of primarily curing or um, fixing um, uh, the impairment. Um, there comes a third factor that I would like um, to touch upon. I think it's also very important um, to to realize that much of the limitations uh, around addressing social factors uh, come as a result from a lack of funding to incredible institutions like the university hospital and the Glenrose uh, Rehabilitation Hospital. Oftentimes, um, uh, these our medical institutions are underfunded in implementing programs that may address social barriers and barriers to inclusion within society, despite the best efforts of our doctors, PTs, OTs, and other healthcare professionals. And this is largely rooted within this kind of neoliberal idea of uh, a cost benefit uh, analysis approach to treating uh, disability. Oftentimes, governments prioritize seeing uh, um, results that are hindered by metrics uh, of uh, of impairment reduction. Therefore, most of the funding um, goes towards effort in addressing medical treatment, but neglect programs like uh, programs that assist in assisted living or programs that may research in new adaptive technology that may result in more independence towards the um, disabled individuals because they don't see a direct correlation between innovation, a- and uh, and I guess in their eyes, disability eradication. Uh, um, uh,
Mhm.
I,
Would you like me
I
to,
sorry,
would you
go ahead.
like to advance your slides? Just double checking.
Yes, you actually came at the right. Oh, one more. Thank you. There we go. There we go. And now, um, I think after after analyzing the so-called problem so far, I think it's important to ask ourselves what solutions we can implement um, to make sure that we're understanding disability more holistically. A- as as I mentioned before previously, I think that uh, the way that society in large thinks about disability is very medically focused, and we don't tend to think about things like policy, infrastructure, um, uh, uh, um, and, and, independent targeted uh, programs that assist individuals with disability in obtaining their independence. So uh, a way we can address this is incorporating um, understandings of the social model of disability, which uh, Dr. Tom Shakespeare speaks uh, heavily about in his papers. I encourage everyone to look up his work. And basically, he argues that the way in which modern society is structured um, really emphasizes temporary and retrofit solutions within our um, society, because we don't tend to build society uh, on universal design principles. Uh, as a result, we um, governments, municipalities um, find or implement solutions uh, much later on within the process, and this results in kind of lackluster um, uh, solutions or ways to incorporate a more universal design outlook. So that's what the social model tries to make us think about: is how does society uh, implicitly maybe un overlook things like universal design, like uh things like a more accessible physical infrastructure. The university uh and the asylum, going back to J. Dolmage, is described uh, very similarly. Uh, And what I mean by that is both uh, institutions are built um, in very extravagant ways, using very steep steps, high walls to symbolize this uh, um, aura of magnificence or deterrence in the case of the asylum. And much of our architecture today is built along those same premises. Um, Luckily, we've gotten better with like building codes to make sure that uh, you know that elevators and ramps are thought of and implemented, but oftentimes what I find and what research finds um, is that these um, implementations uh, of you know accessibility are nothing. mm, the, they are s- th- Give me 1 second. I'm just getting my train of thought back. Yes. Okay. So, sometimes, particularly within older buildings like university campus, um, these retrofits that come to be, especially when upgrading newer buildings, are uh, often nothing more than checkboxes to meet building code. But when you try to use these um, accessible ramps, elevators, or uh, corridors, they're often very hard to navigate through with a walker or a wheelchair. So uh these buildings, especially the older buildings, might meet code principles, but might not really address uh or might not really depict what is actually happening within within these spaces. And so the social model encourages encourages us to think about how we can implement universal design right from the get-go, from the planning phase. And in more modern architecture, we see that to be very much the case. So we are moving slowly as a society to incorporate disabled folks from the get-go in the ways in which we organize society. But we also need to recognize that maybe universal design elements might uh, might allow for specific needs to fall through the cracks. So universal design is a start, but it's not the be all end all. We need to constantly making tweaks and adjustments to our infrastructure, to processes of innovation, in order to make sure that disabled individuals uh, live a um, equitable society as their fully abled peers. Uh, Secondly, would be funding and innovation. I think funding and innovation is an element that is very much uh, overlooked. I spoke about this briefly in my previous point. We tend to fund our healthcare system around around sort of medical treatment, targeted medical treatment, rather than uh, than including things like post-hab um, elements like new mobile devices like walkers and wheelchairs and programs that may assist individuals in their day-to-day living. And I'm so fortunate to be involved um with the Glenrose, who's doing amazing work with what what they've what they've gotten. I'm the vice chair of the Prairie Scan Committee, uh, which is responsible for allocating funds to different innovative projects. And just being in the room with so many talented and passionate and intelligent people shows me that this is what we need more of. This is what our system is lacking. There are so many great uh, minds working towards finding ways and creative solutions to innovate and to create um, to create new technologies that give more independence to individuals with disability rather than just simply focusing on the medical treatment aspect of it, because the medical treatment aspect is incredibly important. I don't want to to to, to downplay that aspect uh, 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 of of uh, of our healthcare system, but there needs to be follow through so that individuals po are able to live free and fruitful lives and not be constrained by things like uh, a steep step or an inaccessible entrance or an ability that they might not be able to do because of the impairment. So you know, innovation like is incredibly important within medical devices, but also, for example, within the home. So, like seeing furniture that is wheelchair level, having stoves that are that 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 um that tend to the needs of individuals who may use one hand as opposed to two, or might not have the full dexterity um as a non-disabled individual. So things, if we continue going down this direction of understanding disability more holistically, yes, we should put put treatment um uh, at the center of what medicine is trying to do, but we should always connect it with with what can we do after the patient leaves the hospital? How can we make sure that the patient is in the driver's seat in terms of their medical plan? How can we meet their goals to work towards um, making sure they are well equipped. And from here, I'm going to ask to go to the next slide. I feel like, I would be doing a disservice if I if I didn't speak about my own personal experiences, because as a junior academic, I strongly believe that personal experience does have a place within research and within um, conversation and deliberation in academia, uh, and and fully believing in this principle, I now attend at, I am now going to attempt to practice what I believe in and sort of give you a more personal and in-depth look or understanding of my experiences within the medical system. So I have been incredibly fortunate to have uh, so many people um, within the medical the medical system here in Alberta touch my lives. Um, it's anyone from doctors to nurses to PTs to OTs, um, to the support staff that just work in these hospitals. These are very, very passionate individuals dedicated to making sure uh, that they can do what or can bring their all um, to making sure that the individuals they serve get the best quality care possible. Uh, and I've been very lucky to be a patient at the Glenrose for for almost 21 years now. And I can't say enough good things about the people there. It's truly like a second home. And I I admire what institutions like the Glenrose um have been doing, because they tend to look at disability again more holistically. So they they um they not only have incredible physicians, PTs, OTs, but they have things like social workers, and they have programs that not only address your medical needs, but your social needs as well. So there are day camps. There are, your social worker can help you get access to supports you may need in the home or outside the home or in the community. So, you know, the everyone um or the system that the and this culture that the Glenrose has built, it, is incredibly important, and I think it's a it's a it's a shining example of where medicine should be heading down, because you are doing a disservice to the doctors, to the OTs, to the PTs, um to everyone who works to collaborate to to um to to to, to treat and to give the best care to patients, if we don't think uh post the hospital stay, or post the surgical procedures. We want to see a lasting impact. And again, having the patient feel like they're in the driver's seat, and not thinking about disability as necessarily something inherently flawed or wrong, or something to eradicate, but something to work with, and to and to accommodate, and to based on the each individual's individual abilities. And I think that's something that the Glenrose does so incredibly well. So massive shout out to everyone uh, at the Glenrose. But again, I think systematically uh, more broadly, our healthcare system in Alberta is not where it should be, because we don't have, we're not we're not at a we're not at a point where we can point to multiple um medical facilities that are um are at the are at where the the Glenrose is at, and that largely has to do again with the kind of the lack of importance around, again, other dimensions of disability. And I know that you know I am personally very, very nervous about where our healthcare um system is heading. There seems to be this conversation and kind of rhetoric around pro- um, um, medical privatization, and and this kind of for-profit model, which raises a whole bunch of alarm bells. Um, because if anything, these institutions are in need of more support, more government support, not less. You know, you know, we've seen a drastic drop in funding to our medical institutions on a per capita basis year after year. Um, so 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 you know, and I think about how these things are coming to be. And a practical example of this is when I turned 18, uh, I requested for, you know, physical therapy to keep going, because it it loosened me up and loosened my muscles up and reduced pain, uh, especially in the wintertime. And the response or sort of struggle I had at the time is, the medical system did not did not did not want to cover um my PT anymore after I was an adult, because it didn't see um a massive, or a measurable uh benefit to continuing um my PT, because they saw my current PT program as nothing more than maintenance to help ease pain and tightness. A- and at the time, at the time, the response I got is, oh, since your PT is more maintenance than it is seeing drastic measurable improvements in your walking, let's say, you know, the you know the the Alberta government isn't willing to cover that, because um there isn't like a measurable goal, you know we can see from continuing this. And then, this was before um I was able to access PT funding via AISH. So it was in this very like tight transitional phase where I had no sort of healthcare coverage. And sort of these are the things I speak about, and these are the gaps within our healthcare system that we need to think about, is that we yeah, yes, like, again, measurable goals are important, and seeing improvement within ability is important, but that's not necessarily all we should focus on. We should make sure that patients within the medical system feel feel you know don't feel distressed, don't feel aren't under constant amounts of pain, or experiencing hurdles or barriers that they otherwise shouldn't, just because, for example, like my PT plan at the time, um just because it wasn't something, uh measurable at the time, and there wasn't uh there wasn't some a drastic, a drastic change we can pin to. I think understanding, treatment as a way in which individuals can live with their disability, and possibly improve their the- their ability along the way, is much more beneficial than thinking about disability in measurable ways, and how we can uh you know eradicate it from existence. And I think that's where, our healthcare system and the bureaucrats and politicians in charge need to start, mm, you know thinking more about, because disability is more than just medical treatment. It's how you're socialized, how you're politicalized, um uh, how you're able to move around, not just physically but socially around society. uh you know and this has a drastic impact on how we view disabled people. if if we do not create a society that is all inclusive, so that we make sure individuals with disabilities can fully participate in all aspects uh, uh, of day-to-day living, we will continue holding uh, a stigma towards disabled individuals, and we will continue holding uh, rep, you know, deeply rooted uh, eugenic ideals that may not be apparent on the surface. So I hope this all all made sense and all was 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 beneficial. Um, I'm happy to clarify or repeat anything that I have previously said. I know that sometimes my stutter makes it difficult to 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 to, to follow along, but yes, that is in short what I have, and I've included some insightful sources that I encourage you all to read. Um, uh, and yeah, I'd be happy to take any questions.